So focus on the liver.
There's these like interesting multiple, and that thing, what's that? Like super dark. Do we
Yeah.
have like
Okay.
old priors? Like I wanna say like hemangiomas, but I wanna see old priors if possible.
Let's just say none of these were here. Okay. But anyway, you're saying hemangiomas because they're nice and T2 bright, pretty well circumscribed. I agree. There's this bigger one here that's kind of dark. Now I'm going to show you this is the pre-contrast. So you can see that this is why there's a lot of hemorrhage in it, but you'll actually see that there was a lot of hemorrhage and a lot of these lesions.
Okay, melanoma.
Great thought.
Neuroendocrine mets.
Oh,
Which
that's
one?
a good one.
Neuroendocrine.
Neuroendocrine. Yeah.
Wait, I want to tell you one more thing, but just one thing about hemangiomas is that hemangiomas rarely bleed. So even though they're full of blood, they do not bleed. So hemangioma off the table. Okay. This is the oh no, wait, that's still the pre-contrast. Arterial. And
do you have subtraction?
Yes.
Yeah. I don't like the way they look.
Yeah, and like there's some that have some enhancements. Others are just mostly hemorrhagic, but they definitely have some enhancement in them. So any
relevant history?
They do, but I don't want to tell you.
All right, fine.
Okay, I will tell you it's a type of met. It's not melanoma. It's not neuroendocrine. So just think about liver lesions that are multiple. So we're thinking mets, and they have hemorrhage in them.
Adenomas, like to
and
hemorrhage.
They can mimic hemangiomas.
HEHE, hepatic hemangioendotheliomas.
That's a great thought. So those are usually young female subcapsular, and they can have,
they have like a halo appearance. It's not, it's a little different.
Show you
capsular traction with
another
hemangioendotheliomas.
So there is a destructive lesion in their temporal bone here. So this was a primary angiosarcoma, and these are their angiosarcoma metastases. And
oh my gosh.
Just a couple of points about liver angiosarcoma. They're often multiple, even if it's primary to the liver, and they're often hemorrhagic. So that's a big clue, is the hemorrhage, especially with fluid levels, which this guy does have some. This person, I don't know the gender actually, but yeah, there's a lot of hemorrhage. So that's one of the big clues. And I think melanoma would be the other. And they tend to have progressive enhancement. These are so hemorrhagic that there actually wasn't a lot of enhancement even on the subtractions, but these were angiosarcoma mets. So very progressive. They were not there a few months ago. So very aggressive.
I'm showing it in reverse of the time that it happened. This is the baryomenoma. I think it's a great fluoroscopic case that illustrates this finding. I have a CT that was done before the BE.
There's intussusception. What is that mass filling defect in the center?
Yes, what is that? So, yep. So we filled, looks good. And then now we're in the right colon. And then now I'm advancing, and there's this thing here.
Like a markedly dilated structure affiliated with the.
Oh, this one's good. It's not here. This one right there. Maybe.
Is it like a cecal volvulus?
Yes. Yes.
Yeah.
You see the turn? The twist is right here. So it twists right there, and it fills the cecal volvulus right there. So we were doing this to try to reduce it because they tried to do it endoscopically, and it didn't work. And then this is at the end, it looks a little better. Not that, looks better than at the early filling. And then here's a CT. So here it is. It's up high on the right there, and there's your swirl down here. So it's a fluoroscopic imaging appearance of cecal volvulus.
Cool. And they didn't end up going for cecopexy or surgery?
No. Patient's much older. So I know they typically do this, and we usually see this in young people, but this patient was older. So I think, there's post-surgical changes, so I don't think it was entirely just congenital, like that we typically see for cecal volvulus.
Nice.
So, okay.
Very cool.
Okay. Okay.
Polysplenia.
Polysplenia.
Azygous continuation of IVC.
Yes. And the liver is on the opposite.
And the liver, yeah, and the
side.
stomach is also not in the right. I mean, it's in the contralateral, yeah, right side.
Yes, but interestingly, their heart is in the proper location. So this is the
the
rarer
spectrum.
form of situs inversus incompletalis or something like that, where your heart is normal, but your abdominal organs are opposite, and associated with azygous continuation and polysplenia. Excellent. So now we're going down, and we can see that the SMA and the SMV are kind of reversed here. And there's actually like all of the small bowels on one side and the colon is on the other side. So there's also an intestinal malrotation where the duodenum never, wait, is it? I think the duodenum never, oh, no, hold on. Well, anyway, just forget that. They're basically like an intestinal malrotation. And the patient was coming in with abdominal pain. And I'm going to show you the coronal. Wait a second, now I can't even see it, hold on. Oh, yes, okay, now I see it.
Oh, the arrow sign.
Yeah. So actually, you know what's funny? I was still looking in the right lower quadrant for the appendix, and the patient had left lower quadrant pain. And this is actually their cecum here, centralized, and this is their appendix. So it was appendicitis, acute appendicitis causing left lower quadrant pain. They went to the OR, they removed the appendix, and this was acute appendicitis.
Nice.
So yes, it was a tricky case, really hard to see in the axial. Coronal is really helpful. And if you have situs, all bets are off. And, you know, even check the opposite side to make sure that you're clearing the appendix on every case.
I love the coronals.
Yes, especially for the appendix.
So the last time we learned about Axios stent, its various functions, and Axios stents can be used to drain if there is a pseudocyst around the around the duodenum. So we are draining the pseudocyst here. We can also drain the gallbladder with the pseudocyst if the patient is poor surgical risk. I'm showing you another case in which the patient was poor surgical risk, had cholecystitis, and they tried to go endoscopically, but instead of putting the Axios through between the duodenum and the gallbladder, they ended up doing something else. Although it's all written, but if you want to like take the case. So basically, instead of going into the gallbladder, they went into the renal sinus. So we see all the contrast.
Yikes.
Going in the renal sinus, and then it's around the kidney and in the renal sinus.
Wow,
So
that kidney is kind of like high, looks like it's a little high riding or something. Like it's going all the way up to, you know, do you know what I mean? Like
yeah,
it looks
yeah,
like it's mislocated. But I guess the anatomy in this case is a little different. Is the patient cirrhotic? It looks like their liver might be shrunken, and so they were kind of a little.
There's like mets or something in the liver.
Yes.
Yeah.
I have another case of Axios.
Yeah, I've seen, I mean, they only do these in patients like who are, you know, non-operative surgical candidates, like usually with stage 4 malignancies or, you know, yeah, with bad prognosis.
Mhm.
So this is another case of Axios stent put between the two, like the stomach remnant and the stomach pouch. And the Axios migrates, and this is what it causes.
Do you have the
Obstruction.
coronal?
Yeah. So that's the Axios, and then there is upstream
Bowel
bowel obstruction.
obstruction. Hmm.
So the axials is still in the lumen, right? Or
Mhm.
is it's not
Yeah.
eroded? Okay.
Not eroded yet.
But maybe full of debris or something, because like it's not allowing things to pass through.
Yeah.
I mean, I doubt it will pass through the ileocecal valve, right? I mean, it probably has to be
Yeah.
surgically retrieved because it's so big and not flexible.
Yeah, they had to surgically retrieve it.
I mean, it probably required bowel resection or at least a enterotomy.
Yeah. And should I show another case right now?
Yes.
Okay, so we saw a case of situs. This is another case of situs, but there's something else happening. So that's the stomach, and
There's a filling defect in the duodenum or something.
Is there like also
Like right there,
side
something
by
looks
side
funny right there. Like a
anastomosis? Oh, and an
intussusception.
intussusception?
Yeah.
yeah, it looks like intussusception. It's a windsock diverticulum,
Oh.
intraluminal diverticulum.
Oh,
Oh,
wow.
cool.
So we actually thought of the first scan was done non-contrast and non-oral contrast, non-IV contrast. So we gave a possibility of intussusception. Then IV contrast and oral was done, and then we gave intramural diverticulum. It was difficult to identify because
Wow.
of the altered anatomy.
Yeah, it almost seems like maybe we should flip the image to try to interpret it. Just
Like right, left. Yeah, yeah.
retrain our eyes.
I agree.
Very cool.
Okay, I will stop share.
This is the patient that presented to us from outside facility with these findings for management. So patient had a stent in SMA, and let me see if I
That's
can
like
show
the
you.
biggest SMV I've seen.
Yes, yes. So, and this is arterial phase. Let me see if I can.
Fistula.
Yep, yep, exactly. So here's the. So you can see it's early arterial phase, and during that early phase, you can see the portal vein is like robustly enhancing, and it's massive. So then, like Aarti said, you're looking for some kind of fistulous communication. So let me go back to the axials, and if we look, so here's SMA. Oh, let me give you the DINs. Actually, DINs might be a little bit easier. Do I have the DINs? These are images from the outside facility. Oh, wait. Okay, all right. There's a little fistulous communication between, here it is, right there, where they stented it. Or you can see that right there, communicating with the systemic veins. Yeah, crazy.
What is that big vein behind the SMV? Can you scroll down?
SMV, yes. This thing here.
Yeah. Oh, it's just like
I
a,
just
it's like
figured
a,
like it's like a collateral, like a systemic collateral, like because I
Mhm.
think the fistula feeds that, so it got really big right there. Sorry, I
Mm.
don't have the thins. But and then I think it then empties into the SMV portal vein right there, maybe. Just
Cool.
from high pressure.
And so despite the stent, it's still continuing.
Yes, yes. So then we placed a stent graft over the stent that was there. This is the angiogram, but yeah. And this is the post-stent graft. And on the post, and so there's we embolize the tract and then put a stent graft over the area that had the fistula. But it's a stubborn one because you can still see pretty robust enhancement of that vein that empties into the portal vein. So there's probably still persistent fistula despite the stent graft and embolization material.
Wow.
Yeah, it's a complicated, challenging case to manage.
Yeah, there's so many collaterals there that probably like several are starting to, they're
Yeah,
fistulating.
it's a chronic, so it's harder to treat, I think, because of that.
Very interesting. Okay, so
What are the
Oh,
subcaps?
what's going on in the portal vein or bile duct or
That's the exact question. Is this the portal vein or is this a dilated bile duct?
I mean, it looks, I want to say biliary system because it wants to go into the ampulla and the pancreas doesn't look
Oh, it's
normally
going to
there.
where the SMV and where the portal
Yeah.
vein should be. And I'll show you this is
Coronal.
venous phase. Oops. Here's the venous phase. So this is actually the portal vein, left portal vein, main portal vein, and it's fistulized with pancreatic pseudocyst. This patient had acute on chronic pancreatitis. So this is what we call a pancreatic portal vein fistula. I've seen several.
Wait, so is that where's this? So I'm sorry, where is the pancreatic communication?
So this is a
That-
pseudocyst in the pancreatic head. The pancreas is all messed up. Like
Yeah.
this is the pancreatic duct.
Oh, and then that little
then it goes
turn
into this like big,
posteriorly empties into the portal vein.
yeah, this collection, and then
Oh my
basically it's
gosh.
just straight fistulized into the portal vein. So,
Wow.
these can be tricky. Like even sometimes people mistake it. Like here, you're like, oh, is it the bile duct, right? But the bile duct is over
Oh,
here,
it makes it so much, yeah, the more
and you can
scubular.
see that it's this
Beautiful.
big fluid-filled portal vein. So I've had actually several of these cases now. You think that this would be like a terrible, terrible thing, but actually, you know, all of my cases have actually done well. They treat them kind of conservatively, even though these are pancreatic juices in here. Your portal vein never recanalizes, but often this will shrink down over time, especially if you treat like the pancreatic problem. So I'll just show you a follow-up. This is
I mean, the fluid in it looks a little bit, oh, the portal vein's out. Oh,
Yeah.
this is post?
Yep, this
Okay.
is the post, and you can see it looks like cavernous transformation.
Yeah.
Like, looks like cavernous transformation, but like the pseudocyst is gone, the pancreas is like, you know, the sort of more pancreatic process has resolved, and then the portal vein never recanalized, and there's still a small little fluid collection here, but most of it is just thrombosed and like shrunken down.
Wow.
Yeah, did well. So that's called a PPVF, pancreatic portal vein fistula. And usually it's treated with medical management with or without anticoagulation.
Patient came in with abdominal pain
Volvulus.
of, yes.
I saw a swirl again. Almost like midgut. Ooh, with pneumatosis.
Yep, yep, yep.
That looks like small bowel pneumatosis. Oh, wait.
So they, go ahead.
I don't know. I saw like two different areas with pneumatosis, like one in the upper right.
Yep, like right here, and then like down here.
Yeah.
A lot down here in the jejunum. And then there's the swirl here. So this was the entire intraoperatively. They said that the entire small bowel was rotated counterclockwise, and they were able to untwist it. Isn't that amazing?
And save all that bowel, or?
Yeah, yeah.
Wow. Cool. Yeah, so midgut volvulus is more common in children.
Sorry, the proximal small bowel was resected, so not the entire small bowel was saved. But you know, you want to save as much as possible, so and they were able to save a lot of it.
Yeah.
The proximal they had to resect, maybe, probably all of this here.
Cool. I feel like we see a lot of swirls, and I don't like, you know, I always tell my residents, like, don't over call, because sometimes we just, if they've had prior surgery, their small bowel is kind of floppy and we see it swirl a little bit, but this definitely has the secondary consequences.
Yes, I think if it swirls and you start to see mesenteric edema, like this case, and definitely pneumatosis, then it's a significant swirl.
In fact, like long time back, I was reading, there was an article which said if there is anti-counterclockwise swirl between SMA and SMV, that's normal, even with the native abdomen without surgery. Let me see if I can find that article.
Anti-counterclockwise on the axial.
Yes, I found the
Okay.
article.
Got it.
I'm sharing it.
Okay. Can I share first? Sorry. So anti-clockwise. So I just
I
want
just
to
sent that in the
chat.
chat.
Okay. How do you tell? So here, sorry, anti-clockwise. So this is the SMV and SMA. So like it's swirled here. It's kind of pinched off here. So I guess that doesn't fit, right?
No.
Okay.
Because that
Although
just
the-
went anti-counterclockwise. Anti-clockwise.
Yeah.
Yours, Nelly.
Sorry, mine was what?
Anti-clockwise.
Okay. That looks like anti-clockwise, no?
That's what I'm saying. But Yashant was saying that if it's anti-clockwise, that's normal.
So, and this is not normal.
Yeah.
No, I sent you the article on chat.
Do you want to share it on
I can
screen share?
share it. Yeah.
Yeah.
1 second.
I think if you have the anti-clockwise without the edema, pneumatosis, dilatation, it's normal.
I think so, yeah.
This one is like completely pinched off the SMV.
Yeah, I think there will be the caveat of like, if we see other signs like pneumatosis, if the patient is bad, if there's lactate rising. So all those things will be taken into account. But if we just see just anti-clockwise swirl without any edema, without any congestion, then it will be normal.
So is that just congenitally how they present, or is it like intermittent, like it's just, clockwise, anti-clockwise, it's like intermittent semi-torsion?
I'm not sure if they talk about intermittent.
I don't know. This is confusing me, but what I can say is I see it swirling a lot, and it's often just incidental in patients with prior surgery that have mobilized, so they don't have like the normal, sort of tethering of the entire mesentery. So I try not to overcall it unless I see secondary things.
Yeah, I agree with Dr. Sekhar. Yeah, post-surgical, if we see, we ignore it if we do not see any concerning signs. And if without surgery we see it with anti-clockwise, again, we ignore it. And as Dr. Tan said, like if we see extra things like edema, congestion, and pneumatosis or any other thing, then definitely we'll call it regardless of clockwise or anti-clockwise.
Yes. Okay. This patient also has cavernous transformation. That's not what I want you to focus on. I'll just point out where I want you to focus. So for example, there is this presacral soft tissue. And as we go up, we can actually see there's quite a bit more here and some widening of these neural foramina and maybe even some here. Very easy to miss on a CT. This patient doesn't have a lot of fat, but what's your differential for like a presacral soft tissue mass?
Extramedullary hematopoiesis, Rosai-Dorfman.
Plasmacytoma.
Plasmacytoma.
Good.
Lymphoma.
And if it had fat in it, we would also think about myelolipoma versus liposarcoma. And if it's involving the sacrum, we could think about sacrococcygeal teratomas, chordomas. So anyway, this patient actually did have a history of myelofibrosis. So this was extramedullary hematopoiesis. And I'll just show you how much easier this is to see on MRI. Actually, this isn't a great phase, but
how is the diagnosis made? With biopsy or with
no,
imaging?
we put it together with the history, but you can see in MRI, you can see there's a lot of soft tissue coming out of all of these things. And then actually, let me see. I think it was even let me try to get the chest CT, but there's even stuff coming out in their chest area.
Oh yeah, and a symmetric. Look at that.
So yeah, anyway, it was extramedullary. Well, this is presumed extramedullary hematopoiesis. I guess that's a good point that we don't have the full diagnosis here, but let me try to get you.
I mean, the bony stuff looks a little bit scary.
Yeah, so you can see it even coming out like paraspinal involving the ribs, all this stuff here, right? They don't have a history of myeloma. Otherwise, you know, plasmacytoma would probably be up there, but this is a really good location for extramedullary hematopoiesis. So that's what we decided we thought it was.
I have a companion case.
Okay.
So this is the case from an elderly female. And we see this fatty and fat and soft tissue density lesion in front of anterior to the sacrum. And we had the differential of liposarcoma. I'll show you the MR. And it has fat, which we saw on CT as well. But because of soft tissue component, we were considering liposarcoma. It was biopsied and it came out to be presacral myelolipoma.
I was going to say, we've had the
Wow.
same thing where it's a myelolipoma. So I really definitely think we should bring that up in the differential because that's a really good spot for it. And then the bones look fine, so it doesn't, because
I mean,
extramedullary
how do
hematopoiesis
you distinguish that from leiomyosarcoma?
from liposarcoma.
Liposarcoma, sorry, yeah.
I think you
Biopsy
have to biopsy it, but you have to bring it up. So it's not just like, you know, presumed liposarcoma. And the other thing is, if liposarcoma is in the differential, you should do core biopsies and test it for MDM2, because otherwise they could just look like big sheets of fat and you can't tell the difference between that and like a lipoma.
Wow.
In fact, I've seen at least 2 or 3 of similar kind, and all of those were biopsied.
Yeah, and I actually feel like this is a good look for a myelolipoma. So we should definitely bring it up. Okay, patient's got a big spleen. But do you guys notice anything else?
Duplicated gallbladder.
Yeah.
Oh, wow.
So I've been waiting for a case of a duplicated gallbladder, and finally my colleague Amir shared this one with us.
I have a case too.
And so it's really cute. And I just want to show you, there's actually a lot of different types of gallbladder anomalies. I did not know this. There's a whole classification system for multiple gallbladders. You can see it in Radiopedia. But anyway, you can have 2, they can share a cystic duct like here, or they can have separate cystic ducts. You can even have 3 gallbladders. So lots of different variations. And basically there's no real clinical significance. They do not have an increased rate of stones or cholecystitis or even cancer. So
this one doesn't, I mean, there's a lot of edema around it.
yeah, but they're not distended, right? And this patient had chronic
Yeah.
disease and portal
Oh, I
hypertension,
see.
and
She's
so there was like
birth-pacing.
other stuff going on. Yeah.
In fact, in one of the conferences, Dr. Perry Picard showed a case of gallbladder duplication. One had acute coli, the other one was normal. I have a case with myself in which one had chronic coli, the other one is normal. I can pull that case up next time.
Okay. I've seen more that when they have the hourglass gallbladder, where it looks like you have 2 gallbladders, but it's like, you know, it's just 2 parts of the gallbladder, and the more fundal part often has inflammation because it's like it can't release its bile because of the ring of adenomyomatosis. So I like seeing, you know, using that as an example, like, okay, here there's 2 different components. One part is inflamed, one is not, but it's not duplicated. But yeah, this was a truly duplicated one.